Hi everyone and welcome to our module on ANS pharmacology. Now in this module we'll be introducing the topic of ANS pharmacology. We're talking about everything from the anatomy to the physiology to neurotransmitters and receptors of the ANS system. Now from your anatomy and your physiology, you remember that the nervous system is divided into two parts, the somatic nervous system and the autonomic nervous system. The somatic nervous system is involved in controlling voluntary activities, whereas the autonomic nervous system, which we're talking about today, controls involuntary activities. For the autonomic nervous system to control the involuntary activities of the body, it will need to control specific tissues that we're not conscious of. So tissues like smooth muscles found in various organs, cardiac muscles found in the heart, and various exocrine glands are the muscles that the autonomic nervous system will be controlling to perform involuntary activities. The autonomic nervous system is further divided into two parts. You have a sympathetic arm and a parasympathetic arm. We'll be talking about the differences between two of these different parts of the autonomic nervous system in the next couple of slides. Now, this picture depicts for us the innervation of the autonomic nervous system with respect to those two different parts. What you will notice is that majority of organs in the body, about 95% of organs in the body, have dual innervation. So, for example, the heart is innervated by the parasympathetic nervous system, this and also innervated by the sympathetic nervous system. Although the functions of these two systems on the heart tend to differ, a general point to note is that the heart is innervated by both of these systems. Now, it's also important to note that we have very few organs in the body that have only single innervations, usually innervations by the sympathetic nervous system solely. We'll talk about some of these organs very soon, but the important thing to get from this slide is the fact that most organs are dually innervated. Now, this is just to remind us about the fact that the nervous system is divided into somatic and autonomic nervous system. Somatic nervous system is involved in controlling organs that we are conscious about. So, the tissues that the somatic nervous system will be involved in controlling will be skeletal muscles because we are conscious of the movements done by the skeletal muscle. Whereas the autonomic nervous system will be involved in controlling organs that we are not conscious about, or organs, visceral organs that contain smooth muscles, cardiac muscles, or glands. And as you can see, the autonomic nervous system is further divided into two arms, parasympathetic on one end and then sympathetic on the other end, and they are both involved in controlling similar organs with a few exceptions. Differences between the sympathetic and the parasympathetic nervous system are numerous. We talk about differences with respect to their origins, that is, their anatomy, their functions, that is, their physiology, and then some minor details in terms of their component. So the preganglionic fibers, the postganglionic fibers, the neurotransmitters, and then the different organs in which they tend to innervate. In terms of their anatomy, the parasympathetic nervous system is said to originate from the craniosacral part of the CNS. Craniosacral meaning that we have some of the parasympathetic nervous system coming from the cranial nerves and then some originating from the sacral nerve. So that's what we call craniosacral. If you can remember your anatomy, the cranial part of the parasympathetic nervous system are cranial nerves 3, 7, 9, and 10. And then the sacral portion will be coming from the sacral segment S2 all the way down to S4. For the sympathetic nervous system, the origin point or the anatomy of the sympathetic nervous system is said to be thoracolumbar, meaning we have the nerves originating from the thoracic and the lumbar part of the spinal cord. So we have thoracic nerves, usually nerves T1 to T12, and we have the lumbar nerves, usually from nerves L1 to L3. In terms of their functions, the best way to remember the functions of these two systems, these two parts of the autonomic nervous system, is the fact that the parasympathetic nervous system is described as being a rest and digest system. So think about every organ controlled by the parasympathetic nervous system being in a rest mode, or organs involved in digestion being more active. And then for the sympathetic nervous system, the function is described as being a flight, fight, or fright system, meaning that organs that are controlled by sympathetic nervous system um, will be organs that will be excessively activated in either of these scenarios, in a flight scenario, fight scenario, or a fright scenario. Moving on to more details regarding the anatomy. If you also remember your anatomy, remember that the sympathetic and parasympathetic nervous system, the components or the neural components are usually divided into two. We have preganglionic nerves and we have postganglionic nerves. The preganglionic nerves are the nerves coming from the central nervous system and the ending at the ganglion. The postganglionic nerves are nerves starting from the ganglion and ending at the organ tissue, either the smooth muscles, the cardiac muscles, or the glands. And where the pre and postganglionic neurons tend to meet is what we refer to as a ganglion. The differences in sympathetic and parasympathetic nervous system also tend to be found in terms of their pre and postganglionic fibers. For the parasympathetic nervous system, the preganglionic fibers tend to be very long, so they start from the central nervous system and extend all the way to the visceral tissue where they are going to be innervating. The postganglionic neuron, on the other hand, tends to be very short. So the postganglionic neuron is said to be found within the visceral. For the sympathetic nervous system, the preganglionic is short and the postganglionic tends to be very long. The second difference or third difference between the parasympathetic and sympathetic nervous system is in their neurotransmitters. We'll talk about neurotransmitters very soon in our introduction to ANS. But it's important to note that the parasympathetic nervous system tend to have just one neurotransmitter involved in communication between the neural system within it. And that neurotransmitter is acetylcholine. For the sympathetic nervous system, on the other hand, we have two major neurotransmitters involved. We have acetylcholine and norepinephrine. We'll talk about that very soon. And then finally, the organs that the innervate also tend to differ. Although majority of organs in the body are dually innervated, like I said initially, the sympathetic nervous system tends to innervate all organs. Parasympathetic nervous system innervates most organs except some few other tissues, like the blood vessels, like the sweat glands, and the adrenal medulla. The blood vessels and the sweat glands are typically solely innervated by the sympathetic nervous system. The adrenal medulla, though some textbooks will tell you that they are dually innervated, some will tell you that they are solely innervated by sympathetic nervous system. I'll explain this very soon when talking about the neurotransmitters. But the exception rule is one thing that you should remember. The exception rule states that all organs are dually innervated except blood vessels, sweat glands, and the adrenal medulla. Now in this picture, the differences for the sympathetic and parasympathetic nervous system is very evident. As you can see, both of these systems have two different neurons. We have a preganglionic neuron. You can see these are the preganglionic neuron for the sympathetic nervous system. This is a preganglionic neuron for the parasympathetic nervous system. And then we have a postganglionic neuron for each of them as well. These are the postganglionic neurons for the sympathetic nervous system, and this is the postganglionic neuron for the parasympathetic nervous system. All you would notice quickly is that the sympathetic nervous system has very short, although it's not really evident here, short preganglionic neuron and very long postganglionic neuron, whereas the parasympathetic nervous system has very long preganglionic neuron and a very short postganglionic neuron. Another thing that you would notice in terms of the differences between these two systems is that for the sympathetic nervous system, the neurotransmitter produced by the preganglionic neuron tends to be acetylcholine. As you can see, all through acetylcholine is produced by the preganglionic neuron. And this is also the same thing for the preganglionic neuron of the parasympathetic nervous system is also acetylcholine. The difference tends to be in the postganglionic neuron. The postganglionic neuron of sympathetic nervous system will produce largely norepinephrine, except at a few sites, whereas the postganglionic neuron of the parasympathetic nervous system would all be involved in producing acetylcholine. And that's usually the major difference. The difference in their neurotransmitter is usually in the postganglionic neuron. For sympathetic nervous system, it is norepinephrine. For parasympathetic nervous system, it is acetylcholine. There's a bit of exception at a specific site. So the site of the sweat glands and the erectile pili muscle in the skin, the postganglionic neurons supplying these tissues for sympathetic nervous system tend to be producing acetylcholine rather than norepinephrine. And also at the adrenal medulla, the postganglionic neuron in the adrenal medulla would produce epinephrine alongside norepinephrine. Usually about 80% of the neurotransmitters will be epinephrine and the remaining 20% will be norepinephrine. These are just exceptions to the rule of neurotransmission. So please remember the exception rules. First exception rule to remember is the fact that all muscles, all organs, all visceral organs of the body are dually innervated except the sweat glands except the adrenal medulla and except the blood vessels. The second exception rule to remember is the fact that for the sympathetic nervous system, most of the postganglionic neurons of the sympathetic nervous system produces norepinephrine, with the exception of the adrenal medulla, where we have a mixture of norepinephrine and epinephrine, but mostly epinephrine. And then at the sweat glands and erector pili muscle, which produces largely acetylcholine. So next, we'll be talking about the neurotransmitters of the autonomic nervous system. So as we saw in the previous set of slides, the autonomic nervous system makes use of two major forms of neurotransmitters. This includes acetylcholine and norepinephrine, and we'll be focusing on each of these neurotransmitters. We talk about how they are formed, how they're released, and the action that they tend to have at the different sites in which they are working in the autonomic nervous system. Starting with acetylcholine. Now remember that acetylcholine is produced in both part of the autonomic nervous system. For the sympathetic and parasympathetic nervous system, at their ganglion, at the preganglionic neuron, we have the production of acetylcholine. And for the parasympathetic nervous system, largely at the postganglionic neuron, we have production of acetylcholine as well. For the sympathetic nervous system, we only have the production of acetylcholine found at specific sites in the postganglion neuron. That is, at sites innervating the sweat glands and the erectile pili muscle. So please remember this particular site in the production of acetylcholine. Let's go through the different steps involved in formation of acetylcholine, starting with the synthesis. For acetylcholine to be formed in a neuron, we first require the molecule, one of the molecules of acetylcholine called choline, to enter into the axon of that neuron. So the entry of choline into the axon of the neuron is made possible by a particular transporter called a choline transporter. And this choline transporter is really sodium dependent membrane carrier. For it to carry choline, it requires sodium to also enter as a co-transport for choline to be able to enter into the axon. Once choline enters into the axon or the neuron of the nerve tissue, the choline would react with a second molecule called acetyl-CoA. This reaction is catalyzed by the enzyme choline acetyltransferase, and the union of choline with acetyl-CoA would give rise to the neurotransmitter acetylcholine. Now, it's important to note that for the biosynthesis of neurotransmitters, we have drugs that could work either by blocking or activating each of the different steps of biosynthesis. In the case of the synthesis of acetylcholine, one of the drugs that tend to block this step is hemicholine. Hemicholine blocks the synthesis of acetylcholine by blocking the entry of choline into the axon. So that first step that requires choline to enter into the axon is blocked by hemicholine, and thereby this will then eventually shut down the entire biosynthesis of acetylcholine. After acetylcholine is formed, it is usually stored within the axon, within what we call vesicles in the axon. How it's stored within the vesicles of the axon is, first of all, it is transported into the vesicles using a particular transporter called the vesicle associated transporter, or VAT transporter. And after it has been transported into the vesicle, it is stored there until release is required. Now, we have some drugs that tend to also block this step in acetylcholine biosynthesis. The particular drug to note is the drug vesamicol, which blocks the storage step in the biosynthesis of acetylcholine. The third step in the biosynthesis of acetylcholine is release, and this occurs in various sub-steps. So the first thing that occurs for release to occur is that we have action potential running down the axon and getting to the axon terminal. Once action potential gets to the axon terminal, it would open up voltage-gated calcium channels at the axon terminal. And these voltage-gated calcium channels, once they open up, they will lead to calcium influx into the axon terminal. And with the excess amount of calcium entering into the axon, the acetylcholine stored within the vesicles become triggered. So the vesicles will start to migrate towards the membrane of the axon because of the excess calcium in the axon. And that migration of the vesicle will lead to exocytosis of its content. So acetylcholine will be released out of the axon and into the synaptic space by a process of exocytosis. So please remember each of these steps. First is action potential getting into the axon. Second is the opening of voltage-gated calcium channels. Second, the third thing that occurs is that there's an influx of calcium and excess calcium in the cell. The fourth thing that occurs is that there's migration of vesicles towards the membrane of the axon. And then the fifth thing that happens is that there's exocytosis of the vesicles, and there's a release of acetylcholine into the synaptic space. The drug that tends to block this particular step of release is a drug called botulinum. Botulinum could be a toxin or a drug. It's toxin produced by a particular bacteria called Clostridium botulinum. So if you are infected with this particular bacteria, you could have excess amount of botulinum in the body, and that can destroy or hamper the release or impair the release of acetylcholine into the synaptic space. The fourth step in the biosynthesis of acetylcholine is the action step, and this action step refers to what happens to acetylcholine once it has entered into the synaptic space. So within the synaptic space, acetylcholine would bind to its receptors. We'll talk about receptors in the next couple of slides. Once acetylcholine binds on the receptors, it would activate the receptors and then perform the action at the different sites um, it wants it's where it is needed. So, for example, at the organ site, the smooth muscles, the cardiac muscle, or the glands, these organs or these tissues would have receptors, cholinergic receptors that would accept acetylcholine, and these receptors are the sites where acetylcholine can perform its action. We have drugs that can either stimulate the receptors by mimicking acetylcholine or inhibit the receptors by antagonizing acetylcholine. So we have drugs that are called cholinergic antagonists and cholinergic agonists. Cholinergic antagonists are drugs that tend to inhibit the receptors where acetylcholine do the action. So they influence the action of acetylcholine by inhibiting acetylcholine, preventing it from acting on its receptor. And then cholinergic agonists are drugs that tend to stimulate the receptors where acetylcholine tend to do their action. So these are drugs that they act like acetylcholine and then they perform the action acetylcholine do at their receptor site. The last step in the biosynthesis of acetylcholine is metabolism. Every structure or substance produced and acting at a particular site will need to be metabolized. Acetylcholine is no exception. For the metabolism of acetylcholine to occur, it requires an enzyme called acetylcholinesterase. And this enzyme is involved in breaking down acetylcholine into two major components, choline and acetate. Remember that choline is the starting product for acetylcholine. So this product will need to be recycled back into the neuron. So once acetylcholinesterase breaks acetylcholine into acetate and choline, the choline will go back into the neuron and restart the entire cycle of biosynthesis, whereas the acetate will be taken back into the bloodstream and converted to acetyl-CoA. Now, we have a different form of acetylcholinesterase within the bloodstream. So this form is called pseudocholinesterase. Remember that the particular version of the enzyme that is breaking down acetylcholine is the one found in the synaptic space. But a version in the blood or the liver, pseudocholinesterase, is also found, and this one is involved in breaking down drugs that tend to mimic um, acetylcholine, drugs that are referred to as cholinergic agonists. Now, drugs that tend to block this step of acetylcholine biosynthesis, drugs that block the metabolism step, are drugs that are referred to as anticholinesterases. These are drugs that block the acetylcholinesterase enzyme and thereby they prevent the breakdown of acetylcholine. This image depicts for us in a nutshell the entire process of biosynthesis of acetylcholine. You can see that the first step starts with the entry of choline into the axon, and you can see that for it to enter into the axon it requires this carrier, this choline carrier. This choline carrier is a sodium choline co-transporter, so it transports both sodium and choline into the axon. Once choline enters into the axon, the second step will be the conversion of choline into acetylcholine, and that requires the enzyme choline acetyl transferase, as you can see. For choline acetyl transferase to catalyze the conversion of choline into acetylcholine, it requires acetyl-CoA. Acetyl-CoA is gotten from glucose, which is converted into pyruvate. So pyruvate is a precursor molecule for acetyl-CoA, and then the pyruvate there is further converted into acetyl-CoA. Acetyl-CoA would mix together with choline, and the enzyme that catalyzes this choline acetyl transferase. As a result, acetylcholine is going to be formed. After the formation of acetylcholine, we have the storage of acetylcholine into the vesicles. Remember that the particular transporter that stores acetylcholine into the vesicles is called the VAT transporter, the vesicular acetylcholine transporter. And after the storage, when axon potentials tend to get to the axon, we have the release of acetylcholine eventually. Acetylcholine is going to be released through exocytosis into the synaptic space. And then this acetylcholine that has been released will act on the receptors found on the different organ sites. These are the receptors called cholinergic receptors. After the receptors have been activated and acetylcholine has done its action, the acetylcholine will need to be metabolized, and the enzyme involved in metabolism is acetylcholinesterase enzyme, as you can see. This enzyme will break down acetylcholine into acetate and choline, and then the choline will be reshuttled back into the axon to restart the entire process all over. The second neurotransmitter of importance in the autonomic nervous system is norepinephrine. Remember that norepinephrine is found largely in the sympathetic nervous system. It's found in the postganglionic neuron of the sympathetic nervous system, and it's really restricted to the sympathetic nervous system. So we don't really see norepinephrine playing a role in parasympathetic nervous system. Now let's talk about this biosynthesis of of norepinephrine. We'll start with the first step, which is synthesis. For norepinephrine to be formed, first of all, we have the precursor molecule of norepinephrine entering into the axon. This precursor molecule is thyroxine. So just as we had choline entering into the axon terminal, we have thyroxine entering into the axon terminal through a particular carrier called a membrane carrier. Once thyroxine enters into the axon terminal, thyroxine is going to be hydroxylated into a particular molecule called dopa, dihydroxyphenylalanine. And the enzyme that catalyzes this reaction is called thyroxine hydroxylase enzyme. Please remember that this enzyme requires a coenzyme to perform its action. The coenzyme involved in the conversion of thyroxine to dopa is called tetrahydrobiopterin. We get that coenzyme from vitamin B9. And this particular step is the rate limiting step for the synthesis of norepinephrine. Without this occurring, without thyroxine being converted to dopa, we will not have the production of norepinephrine at all. So this is a rate limiting step for the production of norepinephrine. Once dopa is formed, dopa is now further decarboxylated into a new molecule called dopamine, and the enzyme responsible for this decarboxylation is dopa decarboxylase. Dopa decarboxylase also makes use of a coenzyme. The particular coenzyme that dopa decarboxylase makes use of is called pyridoxal phosphate. We get this particular coenzyme from the vitamin B6, and together with this particular coenzyme, we have the conversion of dopa to dopamine. Now, we have some drugs that can block this step of biosynthesis, particularly blocking the step of conversion of thyroxine to dopa. And the drug that is involved in blocking this step is called methylthyroxine. So if we are giving a patient methylthyroxine, what happens is that the thyroxine present within the axon terminal, though it has entered already, will not be converted into dopa. And as a result, norepinephrine will not be formed. Remember that this step is the rate limiting step. So if methylthyroxine is blocking this step, norepinephrine will not be formed at all within the axon. The second step in the biosynthesis of norepinephrine is storage. Dopamine that is formed would eventually be stored in vesicles, and it tends to be stored or transported into those vesicles using a particular transporter called vesicle monoamine associated transporter called VMAT. Once it has been stored, dopamine within the vesicle is now further converted into norepinephrine, which is the final step. And the enzyme responsible for this conversion is called dopamine beta hydroxylase enzyme. This enzyme also requires a coenzyme. The coenzyme that it requires is called pyridoxal phosphate, which is gotten from vitamin B6. And after dopamine beta hydroxylase converts dopamine to norepinephrine, the norepinephrine there is stored permanently within the vesicle. Now, please, it's important to note that in specific organs like the adrenal medulla, norepinephrine production does not end there. Norepinephrine is now later converted to epinephrine, and the conversion of norepinephrine to epinephrine is done by a different enzyme called PMNT enzyme, phenyl N-methyl transferase enzyme. This enzyme also requires a coenzyme or coenzyme, yes, to perform its action. The particular coenzyme that is involved in conversion of norepinephrine to epinephrine is S-adenosylmethionine coenzyme. This enzyme is found within the adrenal medulla, and remember that adrenal medulla is involved in production of about 80% epinephrine and 20% norepinephrine. So it requires this enzyme and coenzymes to perform the conversion of epinephrine of norepinephrine to epinephrine. The drug that blocks the stage of storage for norepinephrine is called reserpine, and this is a very important drug to remember. The third step in the biosynthesis of norepinephrine is the release step. The release step is very synonymous to what we have for the release step for acetylcholine. For release of norepinephrine to occur, we need action potential to run down the axon terminal and activate voltage-gated calcium channels. But once those voltage-gated calcium channels are activated, we have calcium influx into the axon. This calcium influx will lead to the vesicles where the norepinephrine is stored, migrating towards the axon membrane. And once the vesicles get to the axon membrane, they eventually release the norepinephrine through the process of exocytosis, and then norepinephrine would enter into the synaptic space from there. The different drugs that can either block or stimulate the release of norepinephrine includes guanidine and bertilium. Guanidine and bertilium are involved in inhibiting the release step. This is similar to what botulinum does to the release of acetylcholine. Remember that botulinum tends to block the release of acetylcholine. And then the drug that is involved in increasing the release or stimulating the release of norepinephrine is the drug amphetamine, which is an illicit drug. The fourth step involved in the biosynthesis of norepinephrine is the action step. Now, this involves the action of norepinephrine at the receptor site. Once norepinephrine has been released into the synaptic space, it would act on the receptors found at different organ sites, found at different visceral tissues like the smooth muscles, the cardiac muscles, and the glands. And norepinephrine tends to work on receptors called adrenergic receptors. We'll talk about these receptors next in a couple of slides. The drugs that are affecting this particular step of the biosynthesis of norepinephrine includes adrenergic agonists and antagonists. So adrenergic agonists are drugs that will mimic norepinephrine and they would act on the receptor sites by themselves, stimulate those receptor sites, and do the same action that norepinephrine will be doing at those sites. And adrenergic antagonists are drugs that tend to inhibit norepinephrine. They act on the receptor sites but prevent norepinephrine from doing their work at those receptor sites. Then the last step of norepinephrine biosynthesis is the termination step. The termination step of norepinephrine is divided further into two sub-steps. The first is what we call the reuptake of norepinephrine. So once norepinephrine has completed its action at the action site, at the receptor site, it will be taken back into different spaces. So norepinephrine could either be taken up into the neuron, into the presynaptic neuron where it was released from, or it could be taken into an extra neural tissues like the liver, or areas where it could be metabolized would also take up norepinephrine. Now, if norepinephrine was taken up by the presynaptic neuron, we call this reuptake 1. And this is the commonest type of reuptake. Usually about 80 to 85% of norepinephrine that was released into the synaptic space after completing the action are taken back into the presynaptic neuron. Whereas we have about 15%, about 20% of the norepinephrine released into the synaptic space taken into extra neuronal tissues like the liver. And this is called reuptake 2. Then we have drugs that can inhibit the reuptake of norepinephrine, thereby increasing the amount of norepinephrine in the synaptic space. So drugs like tricyclic antidepressants and drugs like cocaine are notorious for preventing the reuptake of norepinephrine back into each of these different sites. The second step involved in determination of norepinephrine is metabolism. So the metabolism of norepinephrine usually is done by two different enzymes. If the if we're talking about the reuptake of norepinephrine into the neuron, if the norepinephrine was taken into the neuron, which is reuptake 1, the enzyme responsible for metabolizing this particular norepinephrine will be the enzyme monoamine oxidase. Whereas if norepinephrine is taken back, is taken up in by extra neuronal tissues in reuptake 2, the enzyme responsible for metabolizing it is catechol O methyltransferase enzyme. And we have drugs that also blocks the metabolism steps. And these are drugs that tend to inhibit the enzyme. So drugs that inhibit reuptake 1 and the metabolism by monoamine oxidase are called monoamine oxidase inhibitors. Drugs that inhibit reuptake 2 are drugs that block catechol O methyltransferase enzyme. And these drugs are called COMT enzymes or catechol O methyltransferase inhibitors. In a nutshell, this picture depicts for us all the different biosynthesis steps for norepinephrine. Right, you can see that for norepinephrine to be formed, we need tyrosine to enter into the axon through a membrane transporter. After tyrosine has entered into the axon, it is first converted into dopa by tyrosine hydroxylase enzyme, and then dopa is converted into dopamine by dopamine decarboxylase enzyme. The dopamine is then stored into a vesicle using a VMAT transporter, as you can see here. And then the dopamine found within the vesicle is now further converted into norepinephrine. And that conversion is done by dopamine beta hydroxylase enzyme, as you can see. And during the release stage, once action potential runs through the axon terminal, we have voltage gated calcium channels opening up, calcium influx occurring, and then the vesicles migrating towards the membrane of the axon. And after they have gotten to the membrane of the axon, we have the vesicles releasing the norepinephrine using exocytosis into the synaptic space. Once the norepinephrine gets into the synaptic space, norepinephrine can bind on the different receptors, the adrenergic receptors um, at the post synaptic tissue. And after completing this action, norepinephrine is first of all taken back either into the through the presynaptic neuron called optic 1 or taken into extraneuronal tissues called optic 2. In this different set of tissues, it is eventually metabolized. In the presynaptic tissue, it is metabolized using monoamine oxidase, whereas in the extraneuronal tissues, it is metabolized using catechol O methyltransferase. So the last thing we'll focus on in this particular module will be on the receptors. Remember that each of our different neurotransmitters, acetylcholine and norepinephrine, tend to act via receptors. Receptors found at their different postganglionic tissue or postsynaptic tissues. Because we have two major neurotransmitters, we have two different receptors. So for acetylcholine, the receptors involved in acetylcholine is called cholinergic receptors. For norepinephrine, the receptors involved for norepinephrine are called adrenergic receptors. And we'll talk about these two sets of receptors in the next couple of slides. Starting with the cholinergic receptors are receptors for acetylcholine. So they're going to be found at sites where acetylcholine are going to be released at. Remember that acetylcholine are going to be released particularly in the ganglion, at the ganglion between the pre and the post-ganglionic neurons. So receptors of acetylcholine are going to be found on the post-ganglionic neuron that will be receiving acetylcholine. Also remember that acetylcholine is likely found in the parasympathetic nervous system. In the post is released by the postganglionic neuron of the parasympathetic nervous system. So the receptors are going to be found on the tissue sites where these postganglionic neurons are going to be innervating. So tissues, all tissues of the body, all visceral tissues of the body contain smooth muscles, cardiac muscles, and glands, except sweat glands, except um, the blood vessels, and except adrenal medulla, which are innervated by the sympathetic nervous system. We have two major types of cholinergic receptors. We have nicotinic receptors and muscarinic receptors. We'll talk about these two types of cholinergic receptors next. Let's start with the nicotinic cholinergic receptors. Nicotinic cholinergic receptors are receptors that are referred to as ligand-gated receptors. Remember that based on transduction pathway, we have four types of receptors. We talked about this in our pharmacodynamic model. The four types of receptors include ligand-gated receptors, enzyme-linked receptors, G-protein coupled receptors, and intracellular receptors. The ligand-gated receptors are also called ionotropic receptors, and a very common example are nicotinic cholinergic receptors. This means these receptors are involved in opening and closing of channels, and that's practically how they tend to work. The two types of nicotinic cholinergic receptors that we have include the NM receptors and the NN receptors. The NM receptors are actually part of the somatic nervous system, so we are not really meant to talk about them because they are not part of the autonomic nervous system. So these are receptors that are found on skeletal muscles, and if you remember your nerve and muscle part of your neurophysiology, remember that acetylcholine is also the neurotransmitter for the somatic nervous system, and how this acetylcholine tends to perform its action in the somatic nervous system is through the NM receptors, in the nicotinic M receptors on the skeletal muscle. The one that we need to pay attention to is the NN receptors. NN receptors are receptors found at the ganglion. So for the pre-ganglionic neuron and the post-ganglionic neuron to communicate, remember that the pre-ganglionic neuron for either sympathetic or parasympathetic nervous system will be both producing acetylcholine. So the acetylcholine that is produced by the preganglionic neuron will need to act on a receptor on the postganglionic neuron, and the receptor that they act on the postganglionic neuron is the NN receptors. So NN receptors are receptors found on the ganglion because they are found between the pre and postganglionic neurons for either sympathetic and parasympathetic nervous system. And that's what is depicted in the last part. So you can see NN receptors are found at the ganglion, particularly postganglionic cell membrane. NM receptors are found in the skeletal muscle, so they are part of the somatic nervous system. And the mechanism of transduction is through the increase in sodium influx. Remember that these receptors are ligand-gated receptors or ionotropic receptors, so they make use of ion channels, particularly sodium channels. The second cholinergic receptors we have are the muscarinic receptors. These receptors are different from the nicotinic receptors because they are metabotropic receptors or G-protein coupled receptors, meaning that they are going to make use of G-protein and secondary messengers to perform their action. We have three major types of muscarinic receptors for the ANS system. We have M1, M2, and M3. In total, we have five major types of muscarinic receptors. We have M1 to M5. The M4 and M5 tend to be found in the CNS, but M1, M2, M3 are found in the CNS and the ANS. And because they're found in the ANS, that's why we are referring to them specifically. In terms of their various sites, the M1 receptors are found in the CNS system and the gastric tissues. This is where they're found largely. And the M2 receptors are found in the cardiac tissues, in the heart. And then the M3 receptors are found in all other tissues inhibited by the parasympathetic nervous system and some part of the sympathetic nervous system. The mechanism of action of the muscarinic receptors, because they are G protein coupled receptors, we'll talk about that next. M1 and M3 tend to have similar mechanism. M2 have different mechanism of action. So the mechanism of signal transduction for each of them, like I said, differs. For M1 and M3, because they are G protein coupled receptors, remember that G protein coupled receptors tend to make use of different cascades of molecules, enzymes, proteins to perform their action. All right, first of all, we have a G protein, followed by a secondary messenger, followed by an enzyme, and then last we'll talk about the protein. In the case of M1 and M3, the G protein that these particular receptors make use of is GQ. And because they're making use of GQ, the transduction pathway will make use of the secondary messengers IB3 and DAG. IB3 and DAG would involve the secondary messenger calcium as well. There's usually an increase in calcium level once GQ is activated. And then at the end of the day, the protein that is eventually activated there is protein kinase C. So how it tends to work, remember, is that once we have a drug or once we have acetylcholine working on M1 or M3 receptors, GQ is activated. Activation of GK will lead to the stimulation of an enzyme called phospholipase C. That phospholipase C will lead to the production of IP3 and DAG. IP3 will lead to excess calcium or increase intracellular calcium, and DAG will lead to the activation of protein kinase C. And this is practically how the M1 and M3 tends to work. M2 receptors, on the other hand, have a different mechanism of signal transduction. For M2, the particular G protein it makes use of is GI, and because it's making use of GI will tend to inhibit the enzyme adenine cyclase. Adenine cyclase is responsible for the production of cyclic AMP. So once adenine cyclase is inhibited, we have a decrease in the amount of cyclic AMP in the cell. With decreased amount of cyclic AMP, we have an inhibition of the enzyme of the protein kinase A. And this is how M2 tends to perform its action. Please remember these different things in terms of M1 and M1, M3, and then M2. And this is a picture that shows us the different cholinergic receptors and how they perform their action. You can see nicotinic receptors here. These are ligand-gated receptors, like I said, and they are receptors that will make use of ligands or make use of ion channels to perform their actions. Particular ion channel in this case is the sodium ion channel. For the muscarinic receptors, we have M1 to M5, M4 and M5 are found in CNS, so we're not talking about them. Whereas M1 to M3 are found within the ANS. We'll talk about them. So M1 and M3 are going to be making use of G protein GQ, whereas M2 makes use of the G protein GI, which is shown here. And a bit of M1 also makes use of GS, but this is not so common and high yield. So just remember that M1 and M3 are making use of GQ, M2 makes use of GI. And the effect of all this will be that M1 and M3 would activate protein kinase C, whereas M2 would inhibit protein kinase A. Moving on to the second type of receptors found in the innate system, which are adrenergic receptors. Adrenergic receptors, like I said, are receptors that tend to work with norepinephrine. Remember that norepinephrine is released largely in the sympathetic nervous system by the postganglionic neuron of the sympathetic nervous system, meaning that most of the organs that are innervated by the sympathetic nervous system are going to be receiving norepinephrine. So meaning that these organs will contain adrenergic receptors. So once the postganglionic neuron um, releases norepinephrine from its axon, this norepinephrine will act on the adrenergic receptors at the organ site. Also remember that some of the postganglionic neuron for the sympathetic nervous system also releases acetylcholine, particularly at the sweat glands. And remember that was one of the exceptional rules I mentioned at the beginning of the module. We have two major types of adrenergic receptors, just as we have two types of cholinergic receptors. The two types of adrenergic receptors that we have are alpha receptors and beta receptors. Let's start with the alpha receptors. Alpha adrenergic receptors are adrenergic receptors that are classified as metabotropic or G protein coupled receptors. We have two types of alpha adrenergic receptors. We have alpha 1 receptors and alpha 2 receptors. Alpha 2 receptors are found in the presynaptic membrane. So as we have those postganglionic neurons releasing norepinephrine to the synaptic space, and this norepinephrine is meant to act on adrenergic receptors. Some of the norepinephrine that has been released will go back on the presynaptic neuron, will go back on the postganglionic neuron, and then act on this postganglionic neuron. And the particular receptor that tend to receive the norepinephrine acting on the postganglionic neuron are alpha 2 receptors. And this is important to note. So, in a way, alpha 2 receptors tend to act by reducing further increase in or further release of norepinephrine, because the norepinephrine that was released here will go and act as a feedback, negative feedback mechanism and stimulate alpha 2 receptors. These alpha 2 receptors will shut down further release of norepinephrine into the synaptic space. For alpha 1 receptors are found smooth muscles of various organs of the body. So organs that are supplied or innervated by sympathetic nervous system will contain a lot of alpha 1 receptors in their viscera. And this is a picture that depicts for us alpha 1 receptors. You can see alpha 1 receptors found in blood vessels, found in urinary tract system, found in eye, found in virtually all the organs supplied by the sympathetic nervous system. And this is very important to note. Alpha 2, on the other hand, are found on the presympathetic neuron, found on the postganglionic neuron for the sympathetic nervous system. The mechanism of signal transduction for the different types of alpha adrenergic receptors also tend to differ. For alpha 1, because they are G protein coupled receptors, they will make use of GQ. And because they're making use of GQ, obviously the secondary messenger that will be activated will be IP3 and DHE. This will lead to the increase in calcium levels and the activation of protein kinase C. Alpha 2, on the other hand, makes use of GI as its signal transduction pathway. GI will lead to the inhibition of adenyl cyclase, which will decrease the production of cyclic AMP, and that decrease in cyclic AMP would affect the activity of protein kinase A, usually inhibiting it. So this is a picture that depicts to us the signal transduction of alpha 1 and alpha 2 adrenergic receptors. Alpha 1 receptors makes use of GQ, and GQ eventually will lead to the activation of protein kinase C at the end of the day. Whereas alpha 2 receptors makes use of GI, which will lead to the inhibition of protein kinase A at the end of the day. And these are receptors that are responsive to epinephrine and norepinephrine because they are adrenergic receptors. The second type of adrenergic receptors are the beta receptors. The beta adrenergic receptors are also metabotropic receptors, D protein coupled receptors, and there are three major types of beta receptors. We have beta 1, beta 2, beta 3, and these receptors are found at different sites of the viscera supplied by the sympathetic nervous system. Beta 1 is restricted to the heart. We find it in cardiac tissues. Beta 2 is found in every other tissue organ in the body. They are very, very ubiquitous. They are also similar to what we see in alpha 1 for the alpha adrenergic receptors. Alpha 1 are found in most tissues of the body supplied by sympathetic nervous system. Beta 2 are also found in most tissues of the body supplied by sympathetic nervous system. And then beta 3, on the other hand, are largely restricted to the adipose tissues of the body. So please remember that beta 3 are found in fat cells. This is a picture showing us the beta 1 and beta 2. Beta 3 is not really shown here, but you can see beta 1 is restricted to the heart. Beta 2, on the other hand, is found in every other tissue. It's found in the heart, it's found in the lungs, it's found in the eyes, it's found in different smooth muscles of the GIT, G, and the genitourinary tract as well. Let's talk about the mechanism of signal transduction. So, very quickly, beta receptors, whether beta 1, beta 2, beta 3, are all GS coupled receptors. They are making use of the G protein GS. Because they make use of GS, they will lead to the stimulation of adenyl cyclase. And once adenyl cyclase is activated, that leads to the production of cyclic AMP. Cyclic AMP production will lead to activation of protein kinase A, and this is how beta receptors tend to do their work, either beta 1, beta 2, or beta 3. So this, in a nutshell, explains the activity of all the beta receptors. Beta 1, beta 2, beta 3 receptors are all making use of GS. GS will lead to the activation of protein kinase A at the end of the day through the activation of adenyl cyclase and the production of cyclic AMP. The last part of the slide talks about physiology. This talks about the effect of the sympathetic and parasympathetic nervous system on different organ sites, all right, and also what receptors are found on these organ sites. And this is very important to note, especially for your in course, which will be coming up very soon. So one area you should need to pay attention to would be the organs, the receptors found there, and the actions of the different receptors, because they're going to test you on it. So let's start from the top all the way down, from different organs of the body. Let's start with the eye. All right, so the eye is dually innervated. It's innervated by sympathetic and parasympathetic nervous system. For the sympathetic nervous system, the particular receptors found on the eye includes both alpha 1 and beta 2 receptors. Remember, these receptors are the most abundant receptors for the sympathetic nervous system. So they are found in the eye. For the parasympathetic nervous system, the receptors we find there are the M3 receptors. Remember that M3 receptors are the most abundant receptors in the viscerals innervated by parasympathetic nervous system. In terms of what they tend to do, so for the eye, when we have sympathetic action on the eye, this causes a change in two areas of the eye, the iris and the ciliary muscles. The iris are involved in expanding the size of the pupil, so it increases, either causes pupillary dilatation or reduces, causing pupillary constriction. In the case of sympathetic nervous system, what we see is pupillary dilatation. Another name for pupillary dilatation is mydriasis. So sympathetic stimulation of the iris of the eye will lead to mydriasis, and this is done by alpha 1 receptors. At the ciliary muscles of the eye as well, sympathetic nervous system and the ciliary muscles tend to also have a different action. So ciliary muscles are usually involved in the process of accommodation. Accommodation is the ability for us to change our vision from a far vision to a near vision. So typically we tend to have a far vision, but if we are going to accommodate, we need to change from a far to a near vision. Sympathetic nervous system tends to lead to activation of the ciliary muscles, but it leads to far vision as a result. So it tends to cause far vision, and the particular receptor that does this is beta 2. So we say that sympathetic nervous system tend to cause loss of accommodation because it just maintains the eye in the far vision perspective and does not lead to conversion of the far vision to a near vision. For the parasympathetic nervous system, it's kind of the opposite. So though it's making it of just one single receptor, M2 receptor, parasympathetic nervous system at the iris and at the ciliary muscles tend to do different things compared to the sympathetic nervous system. At the iris, it leads to pupillary constriction, which is also called miosis, right? And that's done by the M3 receptors. And then at the ciliary muscles, it leads to the ability of the eye to accommodate, which is the conversion of far vision to near vision. So we say parasympathetic nervous system is involved in the process of near vision, and that is also done by M3. Now, I didn't add this to it, but note that parasympathetic nervous system is also involved in stimulating the ciliary epithelium, and in doing so, it tends to increase the production of aqueous humor in the eye, and that's also done by M3 receptors within the eye. Moving on to the next organ site, the skin. The skin contains sweat glands alongside motor organs, and the sweat glands and the motor organs found in the skin are not dually innervated. They are innervated strictly by the sympathetic nervous system. And as a result, sympathetic nervous system is involved in stimulating each of these. Remember that if you're having flight, fright, fight situation, you could have a scenario where you're sweating, and this is usually done by the sympathetic nervous system. The particular receptors involved includes muscarinic receptors and alpha 1 receptors. You might be wondering why we're having muscarinic receptors in relation to the sympathetic nervous system. Remember that the exceptional rule states that for the sympathetic nervous system, most of the postganglionic neurons will be releasing norepinephrine, except at the sweat glands. So the sweat glands are the only set of organs dually innervated and also have their sympathetic nervous system releasing acetylcholine instead of norepinephrine. And as a result, this acetylcholine will need to work on cholinergic receptors, particularly the M3 receptors. At the erectile muscles of the skin, we have alpha 1 receptors, which are the receptors that will release, that will receive norepinephrine released by the sympathetic nerves. Moving on to the next organ, the organ of the blood vessels. Blood vessels are also dually innervated. They are also singly innervated by the sympathetic nervous system. They are not dually innervated. All right. Although they are not dually innervated, it's also important to know that blood vessels also contain or possess muscarinic receptors. Though they are not innervated by parasympathetic nervous system, they do have a bit of muscarinic receptors within them. This is important to know, so please don't confuse this. They are not dually innervated, but they have muscarinic receptors on their surface. So they are innervated strictly by the sympathetic nervous system. And because they are innervated strictly by the sympathetic nervous system, we have a mixture of different receptors found there. So we have alpha 1 receptors and beta 2 receptors found mixed within the blood vessels. And these receptors do different things once they are stimulated. If the alpha 1 receptors are stimulated within the blood vessels, they will lead to vasoconstriction of the blood vessels. If beta 2 receptors are stimulated within the blood vessels, they lead to vasodilation of the blood vessels. So this is how sympathetic nervous system tend to control the blood vessels. The fourth organ to talk about is the heart. The heart is dually innervated. Innervation by the sympathetic nervous system is going to be leading to increase in the different functions of the heart. Right, it's going to be increasing the heart rate, which is what we call um, inotropic act, sorry, chronotropic action of the heart. It's also going to be leading to increase in contraction of the heart, which we call inotropic action of the heart. And this action is done by the receptor beta 1 receptor. Remember that beta 1 receptors are found only on cardiac muscles. We don't find them on any other tissue except in the heart. The parasympathetic nervous system, on the other hand, does the opposite. It acts on muscarinic 2 receptors, M2 receptors in the heart. M2 receptors are restricted also to the heart, and stimulation of M2 receptors within the heart will lead to reduction in the heart functions, leads to reduction in heart rates, as well as reduction in contractility of the heart. Let's talk about the other organs. The GI organs and the urinary tract organs have very similar configuration structure in relation to the autonomic nervous system and pharmacology. For the GI system, we have it being dually innervated as well. Now, it's important to note that the dual innervation tends to be at different parts of the GIT. The walls of the GI and the sphincters of the GI tend to be dually innervated. All right, for the sympathetic innervation of the GIT, at the walls, the particular receptors we find at the walls are beta 2 receptors at the walls. The receptors we find at the sphincters are alpha 1 receptors at the sphincters. And activation of the beta 2 receptors at the walls will lead to relaxation of the walls. And then activation of the alpha 1 receptors at the sphincters will lead to constriction of the sphincters. I explain why this is important to note. But the total effects of relaxation of the walls and constriction of the sphincters will lead to the retention of fecal matter in GI. So it allows for GI not to be able to move. So you can say that the sympathetic nervous system will paralyze the GI because the walls are not contracting and the sphincters are closed. So constriction of the sphincters lead to closure of the sphincters. Relaxation of the walls lead to the non-contractile or non-motor part of the walls. So this leads to GI retention. The fecal matter or the food content within GI will just remain there, not going to be moving from one point of the GI to the other. And that is what sympathetic nervous system tends to do. It causes GI retention. Whereas the parasympathetic nervous system innervates also the walls and the sphincters. It does this by use of muscarinic receptors. And once acetylcholine is released into the synaptic space and they are working on the muscarinic receptors, muscarinic receptors at the wall will lead to constriction of the wall, and muscarinic receptors at the sphincters will lead to relaxation of the sphincter. This is opposite to what we have for the sympathetic nervous system. The constriction of the walls in GI and the relaxation of the sphincters of the GI will lead to GI evacuation. So it leads to evacuation of contents of the GI. So all the things in the GI will be evacuated because the walls are contracting and the sphincters are relaxing. So think about this. The best analogy I used to use, I love the using in terms of explaining this, is a toothpaste. So think about a toothpaste. If you want to get the content of the toothpaste out, if you want to brush your teeth in the morning and you want to get the content of the paste out onto your brush, you need to press the wall of the paste, right? Or press the wall of the tube and then open the cover of the tube. So the opening of the cover of the tube is the relaxation of the sphincters. The pressing of the wall of the tube is the constriction of the walls. And that's what we see in parasympathetic nervous system that allows GI evacuation. Whereas if you are not doing anything with the toothpaste, you just drop it and you don't want it to be spilling out, you would want to close the paste, right? You want to close the tube, and then you will not be pressing on the wall. So that's what happens in the sympathetic nervous system, and that's what leads to GI retention because you are relaxing the walls and you are constricting the sphincters or closing the sphincters. This is very similar to what we have in the urinary tract as well. In urinary tract, it mirrors what we have in the GIT as well. So for the sympathetic nervous system, we have alpha 1 and beta 2 receptors. Beta 2 receptors involved in relaxation of the walls. Alpha 1 receptors involved in constriction of the sphincter, and this allows for urinary retention. So we are not going to be urinating as a result. In the sympathetic nervous system, your urinary system is just going to keep the urine within the system. Whereas for the parasympathetic nervous system, M3 receptors are involved. M3 receptors are going to be constricting the walls and relaxing the sphincters, and this allows for urination to occur or micturition to occur. So urinary evacuation occurs as a result of parasympathetic control. For the genital tract and the sympathetic nervous system in males tend to lead to ejaculation, and this is done by alpha 1 receptors. Alpha 1 receptors found on the vas deferens are going to be stimulated, and this will allow for sperm or semen to be ejaculated or evacuated from the genital tract. In males as well, for the penis, the parasympathetic nervous system is involved in the process of erection. So erection is done by parasympathetic nervous system using M3 receptors. Ejaculation is done by sympathetic nervous system using alpha 1 receptors. I didn't add this to the slide, but it's also important to note that the sympathetic nervous system also tend to activate receptors, beta 2 receptors in the uterus. And these receptors, once activated, they will lead to contraction of the um, contraction and relaxation. Alpha 1 and beta 2 receptors are found in the uterus. They lead to contraction and relaxation of the walls of the uterus. And this tends to assist pregnancy when birth or parturition is occurring. So the child can be evacuated out of the birth space. Other organs to note, these organs are actually dually innervated, but we have more action occurring in the from the sympathetic arm rather than the parasympathetic arm. So we tend to be very silent regarding the parasympathetic arm. But it's important to know these organs are actually dually innervated. So the liver, for example, once it has been activated by the sympathetic nervous system and epinephrine is released or norepinephrine is released, this would activate glycogenolysis and gluconeogenesis, and this increases glucose levels in the blood. The receptors that are responsible for this in the liver are alpha 1 and beta 2 receptors. For fat cells, we have beta 2 receptors in fat cells. Once epinephrine and norepinephrine are released on beta 2 receptors in fat cells, this will lead to lipolysis and there will be a breakdown of fats within those fat cells. And finally, the kidneys also tend to be activated largely by the sympathetic nervous system. The particular receptors involved are alpha 1 receptors, beta 1 receptors, and beta 2 receptors. And these receptors, once activated, they lead to the production of renin. And remember that renin is involved in the RAS system, the renin angiotensin aldosterone system, which helps in regulating blood pressure. So once we have renin being activated, this will increase the blood pressure as a result because the RAS system will lead to angiotensin 2 being formed, angiotensin 2 will lead to aldosterone being formed, and that would increase blood pressure from there. And that completes our module on the introduction to ENS pharmacology.